Thank you. I'm going to mess up the filming because I like to move around. And today, it's really important to think about this paradigm shift. You're all health professionals out there. And the take-home message that I want to give to you today is that you have the power to change this. You have the power to change medicine and chronic disease and the way we look at exercise medicine from this day onwards. And it's important to do that. I like to think of inactivity as an iceberg, because this iceberg came upon us very, very quickly. We had no understanding of the depth of this iceberg. And actually, what a paradigm means is just a pattern. And what we've got into the habit of as health professionals is not looking at the science behind why exercise works. We've allowed our processes and the way in which we work within the NHS to drift. And we're now in crisis because we've got huge rates of obesity. In fact, the UK is the fat man of Europe. And also, we've not got anybody really seriously looking at this at a strategic level. And so I advocate we need a paradigm shift. We need to change this pattern from now onwards, because inactivity is the fourth biggest global killer. And the reason for that is when you start to look at it, and I'm a pharmacist, you can't get any more medicalised in drugs and drug taking. But actually, I'm the biggest advocate of moving away from our very medicalised approach in how we deal with patients, particularly with chronic diseases. And we need to move towards incorporating exercise in conjunction with that treatment paradigm. Why do we have to do that? Because 37,000 people in the UK die needlessly every year from inactivity. That's a huge amount. That's a crisis. That's a catastrophe. And they're actually names and faces in your clinics. They're people sat in your waiting rooms that are at risk of dying through inactivity. And these are preventable deaths. And the World Heart Federation identifies that 80% of all heart and stroke death is preventable. So this is actually something that you can do something about. There was a great editorial recently in the British Medical Journal by Elizabeth Badley, and she was very bold. She said physical inactivity, disability, and death are all clearly linked. Well, we know that, but nobody's doing anything about it. And actually, I'd go on to say that it causes immobility, pain, poor symptom control in the majority of our chronic diseases. So it's important that we step back from this crisis and start to look at exercise as a medicine, but also the fact that for that exercise medicine to work, medicine needs you, all of you, to actually change your practice and to influence your clinical decision-making within that consultation. And that's what I'm going to talk about today, because not only do we need your leadership on exercise as a medicine, both internationally and nationally, but we need your influence. How many of you sit on an NHS committee or a collaborative body, or even just within your own practice, to influence the partners within your practice to prescribe exercise to your patients? But most importantly, and this is what is missed in a lot of the economic values analyses, it's about helping patients to take control of their chronic disease and actively manage that, not only as prevention, but also as treatment in the management of those long-term disease conditions. Okay, we just have one more iceberg moment. Only 1 in 3 doctors in the United States gives exercise as a medicine to their patients. I'm a cardiac rehab instructor. 56% of UK patients don't access cardiac rehab post a cardiac event. So let me just reframe that. These are patients who've had interventional stenting, cardiology support, intensive treatment on an acute cardiac ward, very, very expensive drugs, and yet we're not facilitating one of the most cost-effective medicines at all. If there's anything that goes back, do an audit. Every heart event patient in your practice or in your clinic, did they attend cardiac rehab? If not, why not? Are your team supporting these patients to access actually best medicine and best medical practice? 65% of cancer survivors, okay, so in the UK, that represents 1.6 million cancer survivors. Okay, so they've gone through chemotherapy, surgery, radiotherapy, wig specialists, psycho support as well, aren't exercising. Now, the evidence for just bowel cancer alone is that, in fact, if you give an exercise prescription to somebody with bowel cancer, their risk of recurrence is reduced by something between 50 and 60%. So it's vitally important, this is critical medicine, that we're practicing the evidence, because at the moment it's not being practiced. And just finally, on this slide, you can see an inactive person spends 38% more days in hospital. These are patients that are swallowing up huge amounts of CCG monies, and within primary care that's the big issue, but also within hospital as well. There was a brilliant article by Herbert in the British Journal of Sports Medicine, and she said, well, you know, they said, why aren't we doing this? And it was clearly identified in an analysis of health professionals' views and opinions. But the reason is it's a clear lack of knowledge and training within our undergraduate and postgraduate courses. They looked at the time within that consultation, and what was really surprising to me is that they felt they had a lack of success in changing patient behaviour. Now, this is something that we've got to address. We've got to address personally, clinically, as advocates of exercise. But also, it's important that we start to look at these within our clinical practices and clinics. I'd just like to show, from what I say, it's no excuses. No excuses not to prescribe exercise, and no excuses not to give exercise. Okay, I'd like to direct you to a YouTube video called No Excuses, which is run by Nike on the YouTube. Please have a look at it. Type in No Excuse, Nike. It's only 1.5 minutes long, but please look at that. I'm sorry that we're not able to play that. But basically, at the end of it, you'll realise what I'm talking about. It's about not making excuses why we're not giving exercise medicine to our patients, and it's also about supporting our patients on why they shouldn't be giving exercise excuses back to us. And this is about shifting the paradigm, and I really like this slide, because actually it's about working with what you have. It isn't about expensive gym membership, it isn't about expensive equipment or rehabilitation facilities. It's actually enabling patients to use what they have to exercise within their communities, within their environments, and with their families and friends. So let's not overcomplicate this very simple issue. I was really grateful that my colleagues glossed over the NICE guidance. I think this is absolutely critical. This provides a framework, along with making every contact count within the NHS, for no excuses for primary care to be giving exercise advice. There's 5 key things of this NICE guidance. How many of you have implemented this in practice? Okay, stony silence there. The NICE guidance was published last year. It actually prescribes every healthcare professional within the NHS is duty-bound under the NICE guidance to give brief physical activity advice to all adults in primary care. So if you're not doing it, please have a look at this document. It's very important. There's 5 key things. Train all your health professionals, provide brief physical activity interventions, support and signpost every patient to alternatives if they're suitable, to monitor exercise medicine effects with their patients, so that's a recording of blood pressures, HDL levels and everything else in association with the exercise medicine, and record it in the notes. And for those people that find it very difficult to record in the notes, that's why we've got an inactivity epidemic at the moment. It's because nobody tracked what was happening with physical activity for the last 20 years in our general practice population. So this is absolutely life-saving medicine. Most importantly for me is setting out that stall, is setting out that intention to deliver a different quality of evidence-based medicine. So it's about saying, my GP practice provides safe and effective exercise support to all our patients, and demonstrating that to your patients and across the health community. And it's about making every contact count and looking at things in a very surgical way within the practice, in saying, you know, what is available locally? What can we provide? Can we work closer with our health professionals in the community to deliver on this important agenda? And just to put this in perspective, there's just under 700 health professionals in the NHS in the UK. What if just one of those patients who saw one of those 700,000 health professionals was given exercise advice? Because if those health professionals are trained, I'm talking about doctors and allied health professionals, trained at undergraduate level, they see 1 million NHS patients every 36 hours. That actually is an awful lot of physical activity advice every consult. So we've got to inspire to train. And I mean, you know, I've been in exercise medicine now for a few years. It's like training for a triathlon. And this is about every patient, every consult, and having that as a mandate within your clinical practice, and using exercise as a vital sign. Now, this is something that Dr. Bob Salas talks about in the States, but in fact, they've done it very successfully. 1.7 million exercise prescriptions are recorded already by Kaiser Permanente. So why can't the NHS start recording exercise as a vital sign within our own consults? Why can't you start recording and looking at a vital sign of physical activity in every patient? And something that I really like, and I really like this term, and I talk about it later, is teachable moments. This comes from the All-Parliamentary Committee on Physical Activity that was published in April 2014 of this year. And that's what we should be doing. These are teachable moments with our patients and with also our colleagues as well. I'll go on to explain a little bit more. We should be making our patients feel like elite athletes. You alluded to the value of actually that input that we put into our elite athletes. We need to have the same philosophy for our patients. And just to put this in perspective with chronic diseases, in the time it takes Usain Bolt to run 100 metres, the NHS has spent £10,000 on preventable diseases. So, to me, it's very simple. What's brief advice? And Nana very nicely introduced that whole concept. But it's literally about saying to a patient, I'm just going to pretend you're a patient, thank you very much, this is part of the consult, thank you very much for coming to see me. You've got your prescriptions for some medicines, but actually I want to start to train you in understanding some of the implications of exercise and how it's going to help your disease. Stage 1, okay? That's brief interventions. Took me less than 30 seconds to do that, and that's an important stage. If you've got that theme within your GP practice or within your hospital clinic, you can really then start to influence the perceptions around exercise as medicine. So through training, practice, and expertise and capabilities, we start to address some of those barriers. And it's really important to be open here. I'd like to introduce you to B. How old do you think B is? B's 98. She's had Parkinson's disease for 15 years. She's managed her Parkinson's by going to a local non-combat boxing gym. Okay? This is in the States. We don't have it over here. But actually, when you start to look at HIIT training and strength training and the coordination that is required in non-combat and the social fun that they have at this class, this is the paradigm shift that I'm talking about. This is about enabling patients with long-term diseases who have been somewhat failed by the rest of the NHS in terms of support around exercise, can access fun, enjoyable and social physical activity. Out of all of this, I'm a great advocate of exercise is for everybody. And I don't think there's any patients that don't fall into that category. There are, however, 8 patients and 8 absolute contraindications that I'm sure John will check me on afterwards. And they're basically unstable, uncontrollable conditions. So unstable heart failure, unstable diabetes, unstable angina, blood pressure over 100, over 180 over 100. I'm not going to go through the 8, but actually you need to know those because they're the red flags. They're the clinical red flags within your consultation. But I wouldn't be doing my job today if I wasn't actually saying we need to go beyond that. And I'm just going to give you an example. I'd like to think that inactivity is like asthma and the way we treat asthma. Once you get into that paradigm mind shift of how you look at it, and you're not asthmatic, are you? Okay. I'd like you to stand up and just demonstrate to this audience how to use an inhaler. Now, if I'd just given you that, it's all right, you can sit down. I'm not going to really make you do this because I know it's embarrassing. But actually, that's what we do with patients. We say, oh, that's fine, just go and exercise for 150 minutes. What? You know, we've got to look at exercise as a complete understanding of the medicine. And what's worse, the NHS, if you are needing exercise referral, we give them the medicine, and then 12 weeks later, we take it back, simply because the evidence for exercise referral was built on a funding grant that only lasted for 12 weeks. So our whole paradigm of exercise referral, I would say and argue, is fundamentally flawed because it takes the medicine away from a vital condition. Things that need to be addressed is if you've got a type 2 diabetes patient, please tell them that they need to check their feet before and after exercise. This is like telling a patient who needs a beclomethasone inhaler not to wash their mouth out afterwards. If we don't give that critical advice to those patients at a point of enabling them to take the medicine safely and effectively, we're doing exercise medicine a huge disservice. So please learn about all the patient considerations, the clinical precautions, such as patients with cancer with low white blood cell counts, and some of the disease-specific issues, such as Parkinson's disease, what works for Parkinson's disease patients more than other exercises. And that information is evidence-based and it's available. We also, under certain circumstances, need to signpost. And you can see we're moving very clearly away from icebergs, because I don't do icebergs terribly well, to signpost those patients to other health professionals. There are other people out there within your community of healthcare providers that can actually support your aims within your practice, such as physiotherapists, such as exercise referral specialists, such as exercise trainers with a special interest in low back pain and various other things as well. So it's really important to use the health system economically and signpost where appropriate. But for me, it's about cradle to grave philosophy on those teachable moments. Why, when we have a family coming in for vaccinations and immunisations, aren't our practice nurses supporting those patients on exercise and physical activity requirements and signposting mother and baby clubs, you know, buggy push clubs and things like that, all through the patient journey. And specifically to grave, and I'll just talk about, because I have to actually, despite what I say about exercise referral, I'm a huge fan of exercise referral. Inactive individuals, and this was from the Journal of Physiotherapy, inactive individuals decreased in one study from 75% to 53% and reduced the cost of inactivity within that community, that practice community, by up to 22%. So even just making those very simple steps within your practice, you have a huge ability to change that paradigm. Now, I'm going to say something. I'm sure that the sports doctors will see me after coffee. Please stop talking about fit, because nobody understands what you're talking about, okay? Do not say intensity to a patient. The average literacy in the United Kingdom is reading age is between 7 and 8, okay? So talking about intensity doesn't ring it when you're from inner and darkest Doncaster, because nobody knows. And the reason is the British Heart Foundation has already found out this. They've produced an absolutely fantastic document that says, use words such as try and choose, suggestive behavioural mechanisms with your patients. Use effort or how hard you have to try. Talk about short bouts of exercise. Don't talk about 150 minutes because it frightens patients. You know, these are something that they need to start slow and maintain and make it disease specific. Know which exercises work best in each of these. So for asthma, short bursts of activity in moist environments, so things like swimming or martial arts, you know, they're very good activities for patients with asthma to do. And it's about you gaining confidence and using that evidence base to actually change what tools you're using, what opportunities are available in your local communities. I work with Dr. Jo Wallace, who actually comes from Rotherham, which is almost as dark and darkest as Doncaster. But it took her 18 months to change her 6-doctor practice around exercises medicine. They now have Otago classes. All their staff have an exercise class within their surgery, and she runs a walk with the doc scheme as well. But it took her 18 months. So you have to think of this as triathlon training in changing that paradigm shift. And something that's absolutely critical is that we need our patients to meet us halfway. We have to give them permission to start asking us about changes in lifestyle. And this is an awesome NHS poster that I think needs to be in every surgery waiting room. It's about enabling our patients to start asking about exercise and seeing exercise as something that they should do. What exercise can I do, doc? Should be the question within their consultation. Something that I'm very keen about, and I hope you guys are all tweeting, because obviously there's been a Twitter silence while I've been speaking as far as exercise works is concerned. And for those, does anybody follow me on Twitter? Okay, thank you. Thank you very much for following. I hope you're tweeting on my behalf now. But actually using social media is incredibly important. 23 and a half hours, the video by Dr. Mike Evans, was absolutely pivotal in the way in which we deliver health promotional advice and reach more people. I was very privileged to do a project with Dr. Mike Evans. And in fact, I had a conversation with him one afternoon. I said, let's do it in a different language, as you do. You just sort of, ring up Mike Evans and say, can we just do something? He said, well, okay, which language? And I said, well, let's look at Arabic or Mandarin or something like Hindi. And in the end, we decided on Arabic. And within 2 weeks, we got an Arabic translation. And he wasn't convinced. Within 10 weeks, that reached 1.7 million Arab-speaking communities. At the end of 3 months, that had reached 3.3 million Arab-speaking. It outviewed the English version. They watched it for just as long, because it's a 9-minute long video for those that know 23 and a half hours. And actually, that was when you look at it, that was an English video with an Arabic translation, admittedly, but with Canadian humour. I mean, the Grateful Dead references, I'm sure just, but actually people watched it. And I think that we need to look at the use of social media much more proactively, not only at an individual patient level by reaching some sort of hard to reach groups, such as disabled communities, black and ethnic minorities areas as well, and start talking their language of what exercise means to them. Start understanding what is and what isn't available. For example, cardiac rehab is very, very poorly accessed by the Asian community. And that's because often it's in hospital, the facilities are in hospital, they're not within the local Asian communities, or they're not bespoke to their cultural needs. And that's something that we really need to look at. To me, it's about paradigm shifts in patient care. Okay, so out of all of this strategic overview, which is absolutely critical, it's making every patient count, it's making every patient matter. But in the patient's mind to be effective, you have to start linking in some of the great fun, feel-good factors at any age that you can contribute, but also linking that very clearly into the clinical parameters which we're used to seeing as a vital sign, which are blood pressures, lipid profiles and things like that. So the message is, we send back to the patients and within our practice and clinical skills are that we're linking the science behind exercise into our quality patient care. And I'd like to say that I've turned the iceberg drift of inactivity into actually a paradigm shift. And for me, this is the most important thing. And we tweet about it, we talk about it, but actually I passionately believe about this. This is about every single patient that you come into contact with. It's making that contact count on physical activity. And I'd like to think today that, there's some opportunities. I'll pass around some things that we use. Please do not take these away, okay? These are for other conferences as well. If you can just pass those around. It's making sure that you have those tools. Sorry, can you just pass that around? It's making sure that you have those tools within your clinical practices to enable your patients to understand why exercise is, but also for your staff as well. I'd like to say that we deliver quality advice. To me, it is from cradle to grave. This is something that we produce, and actually for cost effectiveness, this is work done by the World Health Organization. And we're just fortunate that the exchange rate actually can is exact. If we actually spend £1 on physical activity promotion via brief advice, then we'll actually get £3.20 saving back within the health economy. Now that is actually better than most drugs, and it's certainly as effective when we look at the 4 ingredients that we need to be prescribing for our patients. And I'd just like to say, my acknowledgements and disclosures, I have an awful lot of great support from people, and great training that I had from the Royal Derby hospitals as well. My disclosures are that I am a passionate physical activity advocate, so I do apologise for that. But also, I'm a member of the World Heart Federation Emerging Leaders Programme, which is looking at preventable disease for heart and stroke patients. So even if you just look at your heart and stroke patients, please, please, please support them on exercise advice every consult. And I've provided lots of really great resources there as well. And I'd just like to say, you can contact me later to please buy my book. Okay, thank you very much. Thank you. Thanks for inviting me.